The most important decision to make before ACL surgery is not necessarily whether to have the surgery, but often it is which graft you're going to use. A lot of patients are not very well informed on that.
Before we get into it, for anyone watching for the first time, can you introduce yourself?
Of course. I'm Dr. Leon Popovitz. I'm an orthopedic surgeon and co-founder of New York Bone and Joint Specialists. I've been in practice for over 20 years, and I specialize primarily in surgery of the shoulder and the knee and sports medicine. My philosophy of orthopedic care and care in general is preservation is the key to longevity. That's something that I have instilled on every doctor that is practicing in our institution. Our goal is to preserve your tissue so that you can have a healthy joint for a long, long life to come.
Why can't the ACL just be sewn back together? Why does it need to be replaced?
It's been attempted many, many years ago, and it failed. The ACL would not heal. The reasons is that the ACL is a central ligament inside the actual joint. So the joint is covered with a capsule, kind of like a balloon. And inside the capsule, there's something called synovial fluid that's floating around in the joint itself. So blood vessels do not actually go into the joint itself. When the ligament tears, the most common location for it to tear is right in the middle, in the mid-substance. It attaches up here and attaches down here, up in the femur bone and down in the tibia bone. The most common location it tears is right in the mid-substance. When it tears in the mid-substance, because it's inside the joint itself, there is no ability to create a real scab because much of the nutrition in the joint is synovial fluid flowing around. So there's no direct vessel going from outside into it. So there's no direct scab. And even when a scab creates, it does not hold because there's fluid flowing around and it washes out that scab away. And we need a scab, we need a blood clot to start healing, to create a scaffold. So everything that you build, everything that you rebuild, everything that you heal needs a scaffold, needs a nice solid platform for everything to build on. And typically in nature, the scaffold is the clot, is the scab. And we can't have that inside the joint. The ACL can't have that, so it won't heal. That's in comparison, for example, to the MCL, which is outside of the joint. It's extracapsular. And when it's outside the joint, the blood flows to it. There's no synovial fluid that's washing away any scabs. So this ligament often heals very, very well.
Is ACL repair ever an option? When is that possible?
So ACL repair has become has returned in popularity in the recent past. It was attempted many, many years ago and it failed because of the reasons we discussed. And then the advent of ACL reconstruction developed, and that's become the gold standard, where we take a ligament from another part of the knee, or we take a graft, and we implant it and replace it for your original ACL, and it turns into a new ligament for you. But now, in the recent past, because of the advancements of fixation efforts, ACL repairs has been used again. The true indication for an ACL repair, there's very specific indications for an ACL repair, is for the ACL to be an avulsion, meaning it tears right off of the bone. It can't be a tear right in the mid-substance. It has to be right off the bone. And the reason for that is you want good amount of tissue. If it tears right in the middle, there's not much tissue to repair, because if it tears right in the middle, this tissue can't be used, so you have to pull this tissue up. There's not enough tissue there to bring up. And also, if it tears right off of the bone, there's actually blood supply from the bone in of itself that could feed the ligament in its healing. So healing, for any kind of repair, you want reattachment, reapproximation. You want the two tissues that need to be healed, they are repaired. They need to be put back together, reapproximated. They need to be fixed, sturdy. You want a nice, strong fixation, so it's not unstable. It has to be a strong, sturdy fixation. And you want blood to flow. So that, for the most part, will meet the criteria for an avulsion. And now we have been doing some ACL repairs for avulsions. But the data is still very limited. We don't have long-term data on that at all. And for the most part, the criteria stands for an ACL repair is an avulsion near near the femoral attachment, and for patients that are not overly active, not high competitive athletes, because they put such a strain on the joint. There's a higher likelihood of re-tear in those kind of patients.
What is ligamentization and when does it actually happen?
So ligamentization is an extraordinary thing. The vast majority of ACL surgeries are reconstruction, where we take a graft from another part of your knee and then we implant it and replace your ACL. The more common ligaments, the more common structures that we use is a portion of this tendon, the patellar tendon, that's over your kneecap. Or we can use a hamstring, a portion of tendon that comes around here, and we take that tendon and we implant it in and fix it with little screws, usually screws, to hold it in place. Then that tendon transforms into a ligament over time. It's extraordinary. It takes about a year, 18 months to do, but essentially when we transplant that tendon from one part of your knee to another, it transforms into the ligament.
Walk me through the 4 graft options as if you're explaining them to a patient right now.
So for that part of the procedure where we take the graft and we implant it, we have options. We have one option is the patellar tendon. Patellar tendon is the tendon that crosses from the kneecap down to the tibia, and it's a nice thick solid tendon, and it overlaps the kneecap. So we can take, what we do is we take a central third. We don't take the whole thing obviously, because then you wouldn't be able to straighten your leg. So we take just a central third of this, and it's proven that the central third does not affect the ability to extend the knee. And then we take that piece and we take a portion of bone from the patella, from the kneecap itself, and from the tibia, and then we implant it, and we fix that portion of the tendon to the femur with a little screw, bone to bone. We fix the bone part to the bone, and same thing on the tibia. We fix it there, the attachment, bone to bone. So the patellar tendon, bone patellar tendon graft, has bone-to-bone fixation, which is the strongest fixation. The majority of the other fixations, such as hamstring, will have soft tissue to bone, which will not be as strong. So typically, patellar tendon bone-to-bone fixation is recommended for high demand patients who are planning on doing a lot of activities, a lot of strenuous activities, heavy labor, heavy lifting, a lot of jumping, pivoting. The higher demand you are, the more likely you should consider the patellar tendon graft. The next option is the hamstring. The hamstring is tendons that cross behind and towards the inner portion of the knee. And we can take a little sliver of that with a very small incision, and we can use that. And we can use it the same way as we did the patellar tendon, but the fixation would then be soft tissue to bone. So the fixation is not as strong. So we really don't recommend patients with the same kind of demand. We don't want to put that same kind of load if the fixation is not as strong. So these patients that you might want to consider, the hamstring, are patients that are active and young, but not planning to be quite as active. A lot of people may want to choose the hamstring over the patellar tendon because when we take the patellar tendon, we have to make an incision in the front of the knee and take a little piece of that bone from both sides. So sometimes when you're kneeling on your knee, you will feel that discomfort or kind of a divot where that little piece of bone was removed. We usually graft that when we finish the procedure. We usually graft that little divot, and we try to minimize the divot as much as possible because we always have a little extra bone remaining. So we try to graft that area and plug it in and fill it in so it won't be as much of a divot. Sometimes people will still have a sensation of discomfort here. Sometimes people will have a sensation of numbness in this area here because there's a lot of skin nerves that are essentially invisible. It can't be seen when we make the incision, but that more often than not returns in a few months, that sensation. So some people want to avoid that kneecap discomfort, so they choose the hamstring instead. But if they are heavy load, planning to do a lot of strain on the knee, high level of sports, high level of physical labor, you probably would consider the patellar tendon more than the hamstring. A note about the discomfort that comes from the kneecap: there's something called patellofemoral syndrome that very often occurs after a knee ACL reconstruction. And that's when the kneecap is not quite centered in the knee and it might kind of tilt a little bit. And when it tilts off to the side a little bit, then it can pinch the cartilage and cause discomfort, kind of nagging, dull pain in the front of the knee, especially going up and down stairs. That usually is because while you're recovering from the ACL reconstruction, the quads tendon up here is weak. It's not as strong. After the surgery, it shuts down. It's natural. It atrophies. So as you're rebuilding your strength, which is a big part of the recovery, the quads tendon is weak and you inevitably get patellofemoral syndrome, and a lot of people have that discomfort. It usually resolves as you fully recover and people manage it just fine. Now that often occurs with hamstrings as well, because that develops because of the quad's weakness from the surgery in of itself and not the actual harvest. And that could occur from the quads tendon graft. It could even occur from a cadaver graft or an allograft. It's because the muscles shut down after the surgery, causing the kneecap to shift a little bit and causing that pinching. But that very often will resolve as you finish and focus on your rehabilitation. The third option is the quadriceps tendon, which is above here. That tendon is kind of the reciprocal, the opposite of the patella tendon. It's above the kneecap as opposed to below. And it has a portion of bone here and then soft tissue all the way up there. When we harvest that, we have a little piece of bone on one side, but we only have soft tissue on the other side. That's becoming used more and more lately. It's an interesting option for a revision procedure. So if you had an ACL reconstruction, you already had your patella tendon, for example, harvested, then the quads tendon is a very, very good option without having to go to a cadaver if you don't want a cadaver. And the fixation for the most part is better probably than the hamstring because it has some bone-to-bone fixation, but it doesn't have bone-to-bone fixation on both sides. So the patella tendon fixation is probably optimal. And then the fourth option is a cadaver, someone who does not want to use their own tissue. There are options where you can use a cadaver, someone who's donated their tissue, and we use that tissue instead. The benefits of that is that it's less surgery on you in particular because we don't have to harvest anything from your knee. We just take the cadaver, we prepare it, and then implant it. The most recent findings of studies on the cadaver are what's called allograft. Allograft is the cadaver. Autograft is your own tissue. Auto yourself is your own tissue. Allo is donated tissue, cadaver tissue. The most recent study on the allograft cadaver tissue shows that patients under the age of 30 really shouldn't have that procedure because they have a higher rate of re-rupture and failure. And the premise is that because patients under the age of 30 are probably more active than the patients over 30, so they have a higher demand.
Which do you use most?
I most commonly use the patella tendon. I think that the bone-to-bone fixation is ideal, and I think that's optimal for patients. And it could be used even for patients who have a lower demand, because wouldn't you want the better fixation?
Is there an objectively best graft, or is it always just a case by case?
No, I've heard somewhere that the best graft is the graft that your surgeon is most comfortable with, because then the surgeon will do the optimal job. Be that as it may, most ACL surgeons are comfortable with all the grafts, but there's no consensus. But for the most part, there's an understanding that the patella tendon graft has the best fixation and probably most appropriate for the most high demand patients.
What is the patient's role in this decision?
It's integral. We discuss all these grafts just like I did now. We discuss all the graft options, pluses and minuses, and ultimately it's the decision of the patient. You know, if a patient is 18 years old and wants a cadaver graft, I would strongly discourage that. So there's input from the surgeon, obviously, and the surgeon has to feel that it's the appropriate decision. So if the surgeon should not be going into the operating room doing something just because the patient wants, but he or she knows that that's not the appropriate thing to do. So it's a decision that both the patient and the surgeon makes.
A 22-year-old soccer player comes in. What graft are you recommending?
So, of course, I would have to evaluate the patient, understand what they're experiencing, the level of activity, determine if there's any significant arthritis on their joint. Hopefully not at such a young age. But in general terms, a highly active 22-year-old soccer player, I would likely recommend the bone patellar tendon bone fixation graft because of higher fixation and young age and high demand.
What if she's worried about anterior knee pain from the patellar tendon? Does that change it?
So there's always pluses and minuses in every surgical procedure, any procedure in general. And like we discussed, the anterior knee pain that comes from patellofemoral syndrome, that dull, achy, vague pain, that's the most common discomfort, really occurs whatever graft you use because it is related to the weakness in the muscle that occurs after any surgical procedure on the knee. And after every surgical procedure, you have to rehab, and build up your strength more. The reason why it's more noticed with the patellar tendon is because we're actually taking a portion of the patellar tendon, and there's sensitivity when you bend, when you kneel on that knee, you'll potentially feel that little bit of a divot. But again, we try to graft and fill in that divot as much as possible so you don't feel it as much.
At what age does the calculus start to shift?
Calculus meaning whether or not when we decide to use one graft versus another. There really is no general formula for that. It's a matter of patient preference and appropriateness. You can have, I've done ACL patellar tendon grafts and use their own grafts in patients in their 40s, and it can be done in their 50s. We can do hamstrings in people in their youngers. So a lot of it is it's specific for the patient, their level of activity and their expectations. But one thing that is really non-negotiable is patients under 30 should not have a cadaver graft, should not have an allograft.
What about a 22-year-old who doesn't play sports? Does your recommendation change?
The fact of the matter is a 22-year-old that tears their ACL has a risk of tearing their meniscus, has the risk of then subsequently causing their articular cartilage to degrade, which leads to arthritis. So when the ACL tears, the knee becomes unstable, makes the meniscus tear. The meniscus protects this smooth lining called the articular cartilage, and if it's not protected, it starts flaking off and the rough bare bone starts showing, and that hurts, and that's arthritis. So again, going back to the concept of preservation is the key to longevity. In this situation, a 22-year-old healthy person, of course 22-year-old is going to be active in life. The person's only 22 years old. So that person really should strongly consider having the ACL reconstruction. And the fact that the person is only 22 years old, that person, in my opinion, should strongly consider having a patellar tendon graft because it has such strong fixation. Because this is one of the cases where preservation actually means surgery. So again, more often than not, a lot of times when we use that concept of preservation is the key to longevity, that often leads us away from surgery, and that's okay. Surgeons should understand and should be willing and prepared to discuss all options, both surgical and non-surgical. And that, when you have that mentality, often you're much more open to non-surgical options, and that's the way it should be, especially when you're taking every patient uniquely into account. But in some circumstances, preservation actually does mean surgery because we want to go in there and fix it so we can preserve your joint. Because if we don't fix that ACL, your joint won't be preserved. It'll degrade prematurely. And we want you to have a healthy joint for a long, long life to come.
What about a cadaver graft? You mentioned that's a real option. When would you use it?
I typically use a cadaver graft for someone who comes to me who may have had an ACL reconstruction with someone in the past and has retore their ACL and needs or wants their ACL reconstructed again. And I typically will use the cadaver for that. But if it's someone under age 30, I would not. I would probably use the quadriceps tendon for that.
You always mention how tunnel placement is critical. Most patients have no idea that's a variable. How important is it really?
It is absolutely critical. and it's a matter of millimeters. So when we do the ACL reconstruction and implant the new graft, we create little tunnels in the femur and in the tibia. One in the femur, one in the tibia. And it's done arthroscopically, where we put a little telescope inside the knee, and we can see everything on a screen, and it's magnified. So it's almost like a microscope television. And we can see everything very, very close. And we have to put the tunnels in the exact spot where the original ACL existed. The ACL is attached on the femur and attached on the tibia. So the tunnels have to go in the exact spot on the femur and the tibia where the ACL was originally attached. If we're off by just 2 millimeters, then the dynamic will be lost. You won't regain that ligamentization where you want that ligament, that tendon, the graft, to turn into a ligament. The ligament will not function properly, and there's an extreme high rate of re-rupture. So the placement of the tunnels are one of the most critical parts of the procedure.
Is this something a general orthopedist gets right, or does it require subspecialty training?
Typically, it's hard for me to believe that a general orthopedist would have enough extra training and experience in doing ACL reconstructions that they would be able to make that determination. But I suppose it's possible, because during orthopedic surgery residency, we rotate through all subspecialties. So I don't want to make any generalities about any particular general orthopedic surgeon, but for the most part, you would have to be a subspecialist who is trained in ACL reconstruction, and particularly someone who has a lot of experience in ACL reconstruction.
Can you correct a bad tunnel during the same surgery?
There are methods we can do to make adjustments. There are. And the more experienced you are, the more capable you are of making those kind of adjustments.
What questions should a patient ask their surgeon about graft choice that most patients never think to ask?
I think that it's important to ask the surgeon about his or her experience. His or her experience in each of these grafts and what they feel is the best for them. Of course, you should have a full discussion about all your options. If you're with an experienced, knowledgeable, well-trained orthopedic surgeon, he or she will be able to give you a good, honest answer as far as what the best option is for you.
What does it mean if a surgeon doesn't have a strong opinion on graft selection?
If the surgeon doesn't have a strong opinion on graft selection and is willing to do any graft for any patient, I would be a little guarded about it. I would be guarded about that. I would say that a surgeon who is experienced and well-trained in ACL reconstruction will promptly know what the best graft is for based on the circumstances. Now, there's a lot of gray area where it could be a young patient that's not quite as active and would prefer the hamstring, and that's a reasonable option. But for the most part, that's the case.
New York Bone and Joint Specialists has a re-tear rate of approximately 1 to 3%. How does that compare to published data, and what drives the difference?
The published data ranges anywhere from 4 to 10%. I've seen even higher than that. And there's a lot of variables. It could be patient population, graft choice, surgeons. All that data you're talking about, you're pulling together, so many thousands and thousands of surgeons potentially, and that data cumulatively. And so it may not reflect the most optimal circumstances, but we're very blessed and proud that we're able to keep that re-tear rate at a very minimal level. And we attribute it to a few things. I think experience, extreme attention to detail is probably first and foremost. I think that's probably the key.
What would you say to a patient who reads a study showing a 20% re-tear rate in their age group?
There are a lot of different studies with different numbers, actually. So it's possible that may have been reported. I would explain to them that, of course, there are complications that occur, and some people do suffer re-tears. In my experience, it's not that high. It's far less. And it's far less here in our entire institution. But But that is the published data. And so that is a reality. And so it's a matter of choice for the patient.
What do you say to a patient who has already decided which graft they want before they walk in?
Well, I would say fine, but let's discuss it further. I would still want to have a detailed conversation about all the grafts. I typically, I get a lot of patients who already have seen other doctors, already have their MRI, or maybe already told they need surgery, and then they come to me. It's important for me and I always say, let's just start over. I start from the very beginning, from the anatomy down to go over the MRI, because it would be wrong for me to make any conclusions or presumptions that the patient has already gained certain knowledge from the other doctor. I want to be sure that we're on the same page. So I would still have that detailed conversation about each and every graft. And after that conversation, if the patient wants to have that graft and I feel that it's appropriate, I'm comfortable doing that graft for them, meaning that I think it's appropriate for them, then that's fine.
How do you handle a patient whose choice you think is suboptimal for their situation?
I'm very honest with them. So if a patient is, 18 years old and wants a cadaver, I'd be very honest. I wouldn't feel comfortable doing that for you. You're walking in with a potential increased risk of re-tear. Why would you want to put yourself through that? So I would have a detailed and open, frank conversation with the patient. If you've been told you have an ACL tear or you suspect an ACL tear and you need a prompt, highly experienced and well-trained opinion, we suggest you come to New York Bone and Joint Specialists. Please give us a call or click. We look forward to seeing you, and we'll take very, very good care of you.